Good afternoon. I'm Dr. Sandra Hernandez, and I'm quite honored to be with everybody this afternoon. I'm looking forward to our conversation with Dr. Cooper, where we will explore sort of moving from concepts of health equity to what we know works and what we're learning about what works. So welcome to you, Dr. Cooper.
Thank you, Sandra. Dr. Hernandez, it's wonderful to be here.
So I thought maybe, I know the audience has your bio, but I thought it might be good just to start with a brief, how did you get into this work? What makes this work personally compelling to you? I think as we think about changing systems, it's always good to know what motivates our leaders. So what brought you into this space?
Well, it's a long story, but I'll try to give you an abridged version of it. I was born in Liberia, West Africa, so small country on the west coast of Africa. And my parents were involved a lot in community work there. My father actually was a surgeon, and my mother worked at the university as a librarian. And the two of them worked together to build a small hospital called the Cooper Clinic. So they were involved a lot in healthcare and in programs to improve community well-being. My mother was involved in like health literacy work and worked on a leprosy control board. So I think I learned pretty early about the fact that there were not always people around me who had all the same advantages I had. So my parents were professional and I went to a private school and all those kinds of things. But living in a country that's a relatively poor country, there were a lot of people who didn't have opportunities to get a good education, to live in a comfortable home. And so I saw a lot of people who were sick and who didn't really have the best opportunities to be healthy there. And I always felt like it wasn't fair. That I felt like everybody should have those opportunities, especially other children. I was really wanted them to have all the things I had. So I always kind of had that feeling that I was going to do something in this area. I didn't know exactly what it was going to be. But growing up in a medical family, I think it was kind of natural that I was, attracted to medicine and healthcare and science. And so that's what I pursued. And when we actually ended up leaving Liberia when I was a teenager because of political unrest and violence there, we came to the United States and we ended up staying here after that because the country then descended into civil war. But I continued my education here and I learned, like, lo and behold, actually, as I started out in Atlanta, Georgia, and then moved to North Carolina for medical school, and then came up to Maryland to do my residency at University of Maryland Hospital. And I really saw that there were very similar problems in Baltimore to what I had seen growing up. There were lots of poor people, a lot of people who didn't have opportunities to be healthy, who had unemployment, who struggled with not having housing or health insurance. And, there were the same problems here. So I thought, well, here's an opportunity for me to make a difference here.
That's great. That's great. I wonder, from your experience both there in Liberia, but also in your, research that you have done with regard to community engagement and how we actually engage community actively in addressing some of the disparities that you name. Do you want to just sort of share sort of what you've learned about community engagement and that, is relevant certainly to the work that all of us are trying to do today in American healthcare system?
Sure. I think what I'll say is that community engagement actually has been the most rewarding aspect of all the work I do. I think that what I didn't realize, though, is that I sort of thought that, since I work in this area and, I care so much about people and their health and well-being, that I thought kind of everyone would be happy to work with me. And why wouldn't they trust me and so on and so forth. But then I learned pretty quickly that, because of a lot of egregious things that people of color in particular have experienced in our society, there's a real justified mistrust of medicine and of science in those communities. And just because I'm somebody who wants to do work with community in that, I may be a woman of color and feel like, I can identify with people in those communities, they don't necessarily feel like they can trust me immediately. So one of the things I learned is that, you really have to invest in those relationships, and you really have to show that you are committed to people, and that this is not just about your career or about a job or a health system, but it's really about fundamentally what you care about as a person. And you really have to take the time to get to know people, know about what really bothers them, what they care about the most, and and where they would really like to see change, and work with them and not come to them with some preconceived notion of what needs to happen in order to improve their community.
So you've written a lot about differences in the way providers communicate with patients and how that affects health outcomes. So that's sort of the other side of the coin. I wonder if you'll share a little bit about what you've learned and are practicing in that regard.
So I've learned a lot, and that's a lot of where my early work focused was, because that's where I really felt like I could see the differences in the experiences of people from disadvantaged communities when they would come into healthcare. I sort of saw that oftentimes those folks didn't get the same advice, or people didn't always understand the challenges they were facing. And, sometimes not intentionally, but people would actually make assumptions that were incorrect and actually end up, delivering care that was not fair or equitable. So, I set out to study that, to basically understand a little bit more about that dynamic, and really showed that, in fact, even when physicians were well-intentioned, that they were actually, spending more time lecturing patients of color and not listening as much, and that they spent more time like on the strictly medical agenda and less on kind of the broader family, work, community context that might be influencing that patient. So after learning that from some descriptive work, we then moved into like, well, how do we intervene here? We also learned more about the fact that a lot of these doctors weren't doing this intentionally, and that, in fact, we measured implicit racial bias using some online tests, the IAT test that was developed by the Harvard researchers. And we showed that doctors had the same level of implicit racial bias as people in the general society, no surprise. And that actually when there was greater implicit racial bias, that doctors communicated more poorly with patients of color. So we knew doctors weren't doing this intentionally. So we really began to work on interventions where physicians would become more aware of the fact that they had implicit biases, but also more aware of their own behaviors and be able to change those. So we really developed communication skills, training programs for physicians that focused on, what we call patient-centered communication strategies. So things like listening more, talking less, showing empathy, like expressing when you really understand or care what's going on with someone, and actually engaging people in decision-making, trying to find out what their opinion is about things, and in using things like what we call teach back, where after you've explained something to a patient, you get them to tell you what their understanding is of what you just discussed, to make sure that you have some common understanding. So we developed those programs for physicians. And then we also learned that, patients from disadvantaged communities also, understandably, because there's a power differential, need support when they come into the healthcare system. So we trained community health workers to coach patients from those communities to ask questions and to state their opinions and to come into their medical visits more prepared. So those were some of our early programs that really showed promising results. And we tested them in patients with hypertension and showed that when physicians were trained and when patients had a community health worker, that it improved blood pressure control. So that was one of my earlier projects.
So here we are, sort of, in the midst of a pandemic in the country and in the world. And we've got an all-out effort to reach some of our communities that are harder to reach with vaccinations and really getting people back into care for regular healthcare maintenance. But we're also seeing declining interest in vaccinations. And I wonder how we would apply some of your learnings around communication and community engagement and work with promotores in helping us get, what I would say is a harder to reach population. I don't like the term necessarily that they're hesitant, although there may be many reasons for that. But I wonder how are you applying that today to the circumstances that we find ourselves in fighting this pandemic?
Sure. Yeah. I mean, first, what I want to say is that, I just want to be clear that vaccine hesitancy actually has decreased significantly in communities of color. So, African Americans in particular, had high levels of vaccine hesitancy in the fall of 2020. But now in the spring of 2021, we're actually seeing very high levels of acceptance of the vaccine among African Americans comparable to whites. And we're seeing among Latino populations high levels of vaccine acceptance. So I think we've done a great job, or I don't know what's happened, but I know that, there have been a lot of efforts going on around the country, including at my center, where we built on those longstanding relationships with our community partners, people who lead community-based organizations, who train community health workers and promotoras, who know the people in those communities, who have gone out and done education, who have, because during the entire pandemic, were connected with these folks, making sure they had enough food and they had a lot of their basic needs met, now are able to go back and say to them, this vaccine is now available, and to provide, education, to answer their questions, and they're trusted. So, I think we've seen a lot of acceptance of the vaccine. Now the issue is more, enhancing access. So I think we're building on a lot of what we've learned about how to be respectful, how to listen to people's concerns, how to communicate with them in a way that they understand, to basically express, address the specific concerns they've raised around not trusting the vaccine's development, and, letting them know that it was tested in people of a variety of different racial and ethnic backgrounds, that there were scientists of a variety of different racial and ethnic backgrounds involved in the process, and that really engaging the frontline healthcare providers from those communities, as well as other faith leaders, other community leaders, and then the outreach workers. And so I think we've benefited from a lot of those lessons, and I think it's paying off. And now what we have to do is to make sure that some of these structural problems that exist, where people just don't have transportation to get to the vaccine sites, or they just don't have access to the internet to sign up for appointments, that we can try to address some of those structural issues as well.
So I know when we've talked about those structural issues, you've mentioned on a number of occasions these partnerships with not-for-profits, sort of extenders, if you will, into the community from our typical places of providing care. I wonder if you give some examples of the kinds of not-for-profits and community-based organizations that have been good partners in addressing some of these social issues that you reference.
Sure. So, one of our partners is an organization called STAR, Sisters Together and Reaching. And that organization has been in the Baltimore community for decades. They primarily focused initially on women with HIV and HIV/AIDS and their families. And so they offer outreach, wraparound services, mental health support groups, The community health workers are there to connect people with resources if they need their, for example, financial assistance, get their utilities paid, or they need to apply for jobs. They need someone to go with them to their doctor's appointments. So, STAR has been an excellent partner. And although they initially focused on women with HIV/AIDS, they've worked with us on programs that address disparities in cardiovascular disease and diabetes, as well as, depression. So they've been a great partner. And then, I think our faith-based organizations, their commitment and their strength cannot be overstated. So we've had a lot of really strong faith-based partnerships. Also, STAR is a faith-based organization as well. Wow. But I'm thinking more about churches. So I have a colleague whose name is La Princess Brewer, who is at the Mayo Clinic, and she's worked very closely with African American churches in Rochester, Minnesota, to implement cardiovascular risk reduction programs that basically are implemented at the church, so in the community, and designed with input from people who are from those communities. And because that infrastructure was in place, they were able to provide a lot of information and connection to resources during COVID-19 as well.
That's great. I know you have a forthcoming book, Why Are Disparities Everyone's Problem? And in it, you call for a new kind of herd immunity. And so I'm wondering if we've been hearing a lot about herd immunity as it relates to vaccination rates in the pandemic, but you've got a different framework for that. So share a little bit about that.
Sure. So I'm really excited about this book coming out because I really want people to see that everyone has a role to play in the solutions. As a society, we're collectively responsible for where we are today, based on decisions we've made and situations we've allowed to come into existence. So, but we also have a role. We can all play a role, no matter who we are and what organization we work in. We can hold ourselves accountable through our own attitudes, beliefs, and behaviors when interacting with people who are from more socially disadvantaged communities. We can hold our leaders accountable within our organizations to make sure our practices and policies are equitable. And we can also be civically engaged and go out and vote and support, policymakers and lawyers who actually support more equitable policies. But the new type of herd immunity that Dr. David Williams and I described initially in a JAMA Viewpoint article was that it's not an immunity that is a biological immunity. We know that that's important, and thank God we do have now several vaccines that are effective, and that if we take them will provide biological herd immunity. But what we were calling for was herd immunity to negative social factors. So we really are not going to achieve really health equity and true health for everyone until we protect everyone in our society, and particularly those that are most at risk from negative social factors. So everyone has basic needs to have access to healthy food, to a good education, to gainful employment, to safe housing and neighborhoods where they can go out and safely be physically active. And then everyone needs access to healthcare. So if we can think of providing that kind of herd immunity, that will protect us from the greater pandemic, which is that pandemic of health inequities that we've had for generations, long before COVID-19 even came. And all it did was basically to expose the problem and show it and magnify it.
So you've talked a little bit about that civic engagement, and many healthcare providers sort of think of healthcare policies as their domain, but so many of the policies that you're talking about that are broader in nature and that are protective of well-being in communities are well outside of health policy. And I wonder at this moment in time, as we're talking about public health needs and infrastructure needs and all kinds of policies that address really structural racism and poverty in particular. How do you think about the federal environment that we're living in today as it relates to getting better herd immunity for some of these social determinants you mentioned?
Yeah, there's so much that could be said about this. So I think one of the things that I'm encouraged by is that, for example, the American Rescue Plan really has placed a strong focus on some of these factors. So the fact that there was a lot of emphasis placed on eliminating childhood poverty, we know that if children get an early start where they can get education early and live in a safe environment, that they are much less likely to develop a number of different health problems, whether it be mental health or substance abuse issues or obesity or any of those negative factors. So I'm so encouraged to see that, some of our policymakers are really looking at these types of issues, raising the minimum wage, so that everyone can have gainful employment and be able to afford, to buy food and to live in, in a safe home. So I think people are starting to see the connections among all these things. I think policymakers are starting to see that. I think it's going to be really important for health professionals to develop what I call structural competency. So, it's one thing we had talked for a long time. We talked about health disparities and we talked about cultural competency. And that was all about understanding like the patient's beliefs and values and, their particular preferences and their religious orientation and things like that, which are incredibly important. But we weren't really talking about things that are in our environment, our social environment, that really, and physical environment that shape whether or not people can be healthy or not. And if doctors aren't aware of those factors and aren't able to kind of help people get connected to supports or advocate for policies that will improve the situation for those patients, then we can focus all we want on the individual patient's beliefs and attitudes or trying to get them to change their behaviors. But if that environment around them isn't supportive of that, then we're not doing our job. So I think for healthcare in particular, we've got to figure out how do we fit in? What's our role in this sort of bigger scheme of issues? We can't solve it all, but how can we be a good partner? How can we find out who are the best partners around us who can address specific issues like the quality of housing and, the affordability of housing, for example, or whether or not, kids can get the right kind of support they need in schools, for example, food, the food system, things like that. Who are those partners that we can work with so that we can assure that the people that we're responsible for caring for can actually achieve health? It's not all over just because we prescribed the right medicine, or we made the right diagnosis, if we didn't also try to facilitate some of the other things. So, I think there's a lot of work to be done, but I'm encouraged by the fact that I think I'm seeing people connecting the dots. For a long time, I think everyone thought health was just all about like doing the right thing, like don't smoke, don't drink, eat healthy food and go exercise and you'll be fine. Well, that's fine if everyone has the opportunity to do that. But if there are other things going on that prevent people from having those opportunities, then they can't do that. And I think we're seeing that if we can work together with our partners and form good partnerships, respecting the knowledge and wisdom that everyone brings to the table, that we can solve this problem together.
So, Dr. Cooper, we are also at a moment in this country where we're reckoning with race. And, you and I are talking today on the 1-year anniversary of George Floyd's murder, which really has sparked an incredible conversation across the country. And a lot of the structural issues that you're describing really come out of policies that are fundamentally racist. And so as you think about this moment, both in terms of what we know about your work and what we've learned on health disparities, this moment of the pandemic, this moment of racial reckoning, I know you're optimistic, and I wonder, how do you see those three forces coming together to really accelerate this vision that you have for a social herd immunity, which I think is really just a compelling vision?
Yeah. Well, I think, this is another example of people being able to connect all the dots, to see how interconnected these different problems are, and also to see how interconnected we are. I think we all witnessed, the horrible death and murder of George Floyd. And, because everyone around the world, so many people were able to actually witness that, we shared that experience, that pain that we saw, and we connected with that person, with another human being who was going through something that was unjust. And, by doing that, I think it awakened all of us to the fact that, it could be any one of us that experienced that. And we don't want that kind of treatment of people in our society. It actually brings harm to everyone. I think so many people were just devastated and hurt by seeing that, and particularly people who could see themselves in George Floyd because they come from those communities. They are African American or other men of color or women of color. So I think that awakening and that that empathy that was generated by seeing that, people are able to see that this is a human condition, and that no one deserves to be treated that way, and that when we allow things like that to happen in our society, it reflects upon all of us. I think that has really sort of provided impetus for real change. And I think, frankly, our country and our world is changing. We have a much more diverse world, and we are much more connected in terms of knowing what's going on with one another. And I think that also provides the opportunity for people to see the potential for change that will actually, by elevating sort of everyone and valuing everyone's humanity, that we all benefit.
I think your point is so relevant. The people who witnessed it in person allowed us all to witness it, right? A young teenager who knew it was wrong and just stood there calmly and filmed it so that we could all see it, I think really has created a sense of courage and humanity for us to recognize that whether you're a Black man or you're an Asian elderly woman in Chinatown, wherever, that we all need to step up to addressing these issues. And so I think you're quite right that it is a moment in which we all share that humanity and recognize that is not a world that we want to live in. So I appreciate those remarks. Let me ask you in closing, maybe, Dr. Cooper, we are, as a healthcare system, really needing to get out of our facilities, as you mentioned, be more civically engaged, getting involved more in community. Is this something that you see is a movement happening within healthcare? Is it a particular moment in time where we have more momentum? What's your prognosis for our ability as a healthcare system and a hopefully increasingly wellness system? What's your prognosis for what this looks like going forward?
Yeah. Well, see, I'm sort of an eternal optimist. I think I have to be for the field that I'm working in. But yeah, I do feel like there's a turning point here, and I feel like there is a lot of momentum. I think the concern that we have to hold up is that, we don't become distracted, as soon as this moment passes by something else that seems to be the next thing. But because we need to remember how devastating this time has been, particularly for the entire country, but particularly for those that are impacted by inequities on a daily basis. And, I think what we're going to need to do is to make sure that we don't forget, and one of the ways we do that is that we actually make sure that we change the ways that we practice, and the policies, so that we don't just go out and protest, or we just don't write papers about the fact that this is wrong or whatever, but we actually translate those words into action. So we make a commitment to establishing a new partnership, whether it's with a specific sector of the society or a specific organization. We look really carefully at our mission and statements, our visions, and have we incorporated that value of equity in there? And then how is that actually operationalized in the policies we have? Are we encouraging people from diverse communities to be part of our workforce and among our leadership and among our governance? Are our practices, are they creating opportunity for everyone, or are they systematically advantaging some groups over others? We're using data to inform our decisions. We're continuing to do that. So we're putting the structures and the resources in place to be able to examine those things and to hold ourselves accountable. So if we have to monitor ourselves, and we have to see how we're doing, and if we're not achieving that progress that we had hoped to achieve, we have to go back and figure out what it is we need to do differently. Again, all in partnership with the people who are experiencing these issues, because they have wisdom. There are a lot of strengths in those communities, and we need to draw on those strengths, to get to the next level. So I'm optimistic. I think there's a good prognosis, but I also think that there are some of us that are really going to need to remain the conscience of the larger systems that we work in. And so, we have to stay strong, and we have to support one another through this effort.
Well, I'll just say from California Healthcare Foundation, we are very much following your learnings and your teachings in all the ways that you've expressed them. I think we really do need to not forget and learn. We do need to take what we know from the data and the science and make it actionable. And as you said, I think all of us really need to recommit to the principles that you've described here this afternoon. So on behalf of all of the audience that are with us today, and all of us doing this work all across the country, thank you for your extraordinary leadership, your commitment, and really your research, which is both actionable and really compelling for all of us. So thank you for your leadership, and thank you for letting me talk with you this afternoon. Be well.
Thank you, Dr. Hernandez.